This is the first annual Essentials of Limb Deformity course. So it's a little grandiose because we don't know if there will be a second, but we're hoping there'll be a second, a third, and more. And so we really need your feedback about this course. A couple of things about this. This is really supposed to be introduction into how to assess limb deformity. It's not supposed to be a comprehensive course. A number of the speakers, or at least two, are part of more extensive courses, and if you want to be involved with those courses, or maybe many of you have, but you're certainly welcome to do that. This is not meant to replace these 3- and 5-day courses. This is meant to give you an introduction. On the other hand, it's supposed to give you the kind of background that even if you don't ever want to do limb deformity, if you're not going to pediatric orthopedics, you're going to do sports, total joints, that this information should be helpful. And I'm going to go over the LLRS AIM classification system. This is something that's coming out hopefully in core in the next couple of months. It's not really that critical that you know this, but the concepts I think are important. But a lot of people don't really know how to measure limb deformity, even in residency. And as we go through, I think more and more people are understanding how to do that, but it's not nearly as straightforward as when people measure the Cobb angle for scoliosis. So our concept is to have a method to be able to do that, and then to end up with a score or index. And that's what this is all about. A number of co-authors helped with this, and it was really devised here through the expertise of the people in the Limb Lengthening Reconstruction Society. So the idea is that there are classifications or index, and this is really more of an index. It defines and differentiates a group of disorders. So lower extremity disorders is a large group of disorders. It's really the heart and the core of what orthopedics is all about by virtue of its name, and it really crosses over to just about everything that we do, even sports and adult reconstructive surgery. It's not really a score. There are a lot of scores out there which measure how well you did and function afterwards. And the LLRS is going to work on developing a score. I know a number of different people are involved with that. But this is really a way of classifying up front. One of the advantages to something like this as we move forward is that even though there are a number of different systems out there to do this, there's none that's really globally used. So you have to get a disease specific, and there are so many diseases it gets very confusing. So why would we want to do this, and why is it important for you? Well, one, it gives you a common methodology, which is most important. And I'll go through that briefly, but you've got some of the world's experts here that will actually go through it in detail. So when you leave here, everyone will be able to understand the methodology. It helps to differentiate a simple angular correction from more complex deformity. So when you look at this, you can say, man, this is going to be too complex. I need to bring someone else in to help, or this is something I think I can do. And hopefully it'll also give us a common language. So if we're speaking to someone over the phone, or if we're writing a paper, we can get a better idea that we're comparing apples to apples and oranges to oranges. So this score is fairly straightforward. It's called the LLRS AIM classification system because each one of those letters stands for something. And the problem I've had with mnemonics is that you forget the mnemonic and then it's useless, right? So this is fairly straightforward. Let's see. It just goes LLRS, and each one of these stands for something. So the L stands for the location. Other L stands for leg length inequality. R for risk factors. S, soft tissue assessment, angular deformity, infection, motion and subluxation of joints. It's not critical you memorize this or even know this at the end of the day, but you're going to learn the technique, the methodology, and that you will know. So how do you use this? Well, you start out by doing a standard technique, and this is what you'll learn. You measure mechanical axis deviation. You measure all angular deformities of long bones. You measure joint alignment, and then you assess for these other risk factors, and you come up with a score. So let's just move forward a little bit. So you measure angular deformities of long bones at all sites, including joint alignment and using the malalignment test. And then the largest deformity is the primary focus, and then you look for these other risk factors. If you break it down then, you go through here, you'll see that location number deformities per limb greater than 10 degrees. So that gives you a number and a score, a 0 through 4. So complex patients with multiple deformities obviously be scored higher. Limb length inequality is estimated at skeletal maturity. Greater limb length inequality is higher than lower. Risk factors, again, you add 1 through 4. Soft tissue 1 through 4. And notice these all begin with the appropriate letter. So location, limb, risk factor, soft tissue. Then you look at the degree of the largest angular deformity. That gives you a number if there's an infection. And then you look at motion stability of the joint above or below. Now, you might wonder where we came from this. Did we just pull this out of thin air? And the answer is sort of yes and sort of no. This was expert consortium where we went through and we said, how much should these score? What are the most important things? We had several more categories, and we sort of broke it down to this. So at this point, this is largely expert opinion. Then we decided what would be more minimally complex to more higher risk complex using the downhill skiing scoring system that has not actually been fully validated, but at least it's relatively easy to remember. So here's the technique, and you're going to learn this technique. You don't in quite a bit more detail, but you measure the mechanical axis deviation, and this is not an acceptable X-ray to do so, but just for example. You measure angular deformities of all the bones, you look at the joint alignments, and then once you measure those angles, which that's what you'll learn today, then you'll look for other risk factors, including leg length inequality, soft tissue, infection, bone quality, and motion subluxation of the joints. So if we do that for this patient, 6-year-old female, no medical problems, leg length inequality of 3 centimeters, tibial torsion of 15, no skin or soft tissue findings, no other medical issues, limited range of motion. None. You can go through this score and say, okay, there's 2 deformities, so that gives me a 2. Limb length inequality, estimated skull maturity is 3 centimeters, that gives you a 1. There's your angular deformity, and there's rotation. So angular deformity is 30 degrees, that falls, or what was it, 20 degrees, because that should be, this should be 89 degrees, so that's 20 degrees. So that gives you a 1, and then your final score is 4. Don't worry about doing that because you're going to, by the end of the day, you'll know how to do that pretty easily. The nice thing about this is if a number of people do this, you actually get very similar results. So if you ask 8 or 10 people on your table to come up with a number, most everyone's going to come up with a number that's going to be 3, 4, or 5. And that would be moderate complexity. Here's another example. Again, you start standard fashion. You get a decent X-ray, of which this doesn't count. But you measure mechanical axis deviation. You measure angular deformities of the bones. You look for any joint malalignment, and then you assess other issues. Here are the other issues that are given to you, and then if you go through the score, you just tally up the score. So 1 deformity, limb length inequality would fall into a level 2. Maximum deformity would be a level 2 because it's 30 degrees. You have dysplastic bone. When you end up, it's a 7. So does this make sense? We did look at statistics to see if inter and intra-radial reliability is reasonable, and actually, as it turns out, to get to the end, that it is very reliable. So that means that people from various degrees of expertise, if they score it and then they rescore it, or if they score it and they compare it to other people, they get very similar numbers. We also asked, when we did this study, we asked people just to rank how complex these cases were, like which one's the worst, which one's the best. We found that even among experts, there wasn't a lot of agreement. As you might guess, some people thought some cases were the worst, some cases thought other cases were the worst. But if you'd sum that total and say, okay, all the experts in general think these are the worst cases and these are the easiest cases, this correlates quite well with that. So it gives us some idea that actually there's some validity or meaning to this score. So the LLRS AIM score is designed to determine severity and degree of complexity. As we talked about, intra-rater reliability is high. There's little agreement between raters on their patient rankings, but this correlates with the worst cases. And I think a lot more work needs to be done. This score may or may not end up being a useful, valuable tool, but the concepts of how to go through this are really important, and those concepts are what you'll learn today. So with that, I want to stop.